Thank you. Yes, I think I'm unique in having purchased 2 of these machines, which is probably why I've had an invitation to come today. So thank you. I'm the light relief. I've got a little bit of presentation anxiety because these eminent speakers have been detailing stuff that for me is just out of the world, and it's fantastic. So I hope you'll forgive my presentation. Dentistry is always looked down upon by veterinary surgeons. You know, it's not taught in universities, it's just ignored. But hopefully I'll just give you an insight a little bit into how I use the Vimago system, and then we'll have a look at a few cases which I've selected, not quite at random, but from my caseload. So in veterinary dentistry, visualization is absolutely the key. And this is why I begin my day by putting on a pair of loupes, and I'm wearing those loupes until 6 o'clock at night when I'm finishing my operations. And the problem that we have is that 2/3 of our dental structures are encased in bone, and so there's no way we can look at them. So we need to use imaging of one form or another to actually see what happens. And this was an X-ray that I was sent by a colleague, and I was asked to interpret the dental pathologies that were going on. And it's a bag of spanners. There's no way you can look at this sort of thing. So obviously we now look at intraoral radiographic series. We do a sort of series of set plates, and with a size 4 sensor, you can get a pretty good set of images fairly quickly. With a size 2 sensor, it takes you a lot longer. This is just half the mouth, so it takes you a long time to work away around the whole system. The other problem that we have is that skull shapes in our animals can be very, very challenging. We're going to get overlap of the tissues, and we're going to get problems with that to allow us to interpret the images properly. And not only that, but just in a normal anatomy, we have problems with superimposition and shadowing in our standard X-rays. And the classic example is the upper carnassials. And with these, our standard projection will overlap the buccal and the palatal images. And if we say using our standard X-ray, that's the sort of thing that we get. And so we then have to shift the head to try, using the slob rule, to separate out the roots to allow us, to differentiate those different roots. And that's fine, and I'll come back to that in a later case in a moment. So using a flat panel CT, using a high quality imaging system, to me was an absolute no-brainer in terms of improving the quality of care I could hopefully provide for our dental patients. One of the problems that we have, though, is that in the UK, and it sounds like in Italy too, we have hypersensitive registration regarding radiation protection. And this is great, it's fine, it's super, but we're going against evidence-based medicine. Using the example of standard digital X-rays, there is no extra exposure if you are 2 big paces away from your dental X-ray unit when you're shooting the beams vertically down. So considering scatter radiation, you have no extra exposure. However, our radiation protection legislation says we have to have gowns and thyroid protectors and all this other jazz. It's a nonsense. So we're required to have a separate room, and it has to be lead lined and no personnel present when we're using cone beam CT, which is, I say, bizarre. We had an inspection and real-time monitoring of our exposure levels, and the guy was astounded by the fact that we had 0 leakage of radiation from the room whatsoever. He said he'd never seen anything like it, but just crazy. So this is my dental operatory. We have sort of 2 active tables, and there's room for a 3rd and a 4th table there. These things here are the most expensive bits of lead glass that you can buy in Europe. Okay, so there's £30,000 worth of lead protection in this room because of these big screens. But it does mean that I can see what's happening on the other tables, and it keeps the room looking very bright and light. And there's our cone beam CT room. We were talking about having 13 square meters. I beat it. Okay. Okay, you can achieve a cone beam CT in a tiny amount of space. but it does take a bit of work. So there's my cone beam CT. Wide angle lenses make the room look bigger, of course, so it's nice. But we can use it and we can incorporate it into our workflow by taking the patients from the dental table out in the cone beam and then back again. But it does mean that typically we're doing a cone beam at the start of the procedure and then maybe do another cone beam, HDVI. I need to change my terminology. Do another HDVI at the end of the procedure to see what sort of a mess we've made of things. So looking at our positioning, we've got a degree of flexibility because we're using the little voxels, so we don't have to have that perfect alignment that we try and get with our standard CTs. So we have a little bit of flexibility, but still, as a matter of professional pride, we do try and keep these things as straight as possible. So for our heads, we tend to use ventral recumbency. We try and aim to have the whole body straight, and certainly the head and the neck, we want to try and get straight, for our positioning. And the other thing that, again, is sort of unusual, if you like, in veterinary dentistry or for dentistry, is thinking about the position of the ET tube. Because you will get artifacts from the CT connector, from the ET tube connector, especially if you have the old metal connectors, it really screws things up. But also a lot of ET tubes will have the radiographic marker running down, so again, you can get artifacts from that. And so when we're looking at taking images of the mandible, we try and lift the ET tube up and get it out of the way of the mandible. And similarly, when we're looking for the maxilla, we try and compress the ET tube down so it's out the way. So this is why we love having packages arrive with lots of foam, because we reuse that foam to move things around. So this is the CT equivalent of a dog with a number of tennis balls in its mouth, I guess. And it allows us to space out the soft tissues, so we're moving the soft tissues away from our dental structures, and so we can differentiate soft tissue masses a little bit easier by doing that. So in terms of let's say placement, we'll be using the foam above and below the ET tube, and then lifting the lips out the way as well. So a large number of bits of foam shoved in this poor little dog's mouth with that. It's remembering to take everything out at the end of the procedure as well. So there's our dog positioned in the scanner, and that's the sort of straightforward image that we get. Now I love the 3D reconstructions, but most importantly, the clients love them too. And I know that we're highbrow intellectuals here, but at the end of the day, someone's got to pay for the CT scanner, and it's going to be the clients. And so having client acceptance of the CT scan and getting their buy-in to having its use is really important. And that's what's going to fund the next one, and most importantly, fund the cost of the servicing as well. So we present the clients with a selection of images when we've performed scans, and always we try and give them one that they can then recognize as their own dog, albeit with the lips pulled out and things like this too. So there's our sort of standard starting point. And then obviously stripping away the soft tissues, and the software is great for this sort of thing. But this is the other feature that we need to think about when we're looking at our images is the resolution, the quality, if you like, of the image. Now 0.25 mil voxel is fantastic quality. You show this to orthopods who've got a 2-slice CT or something, and they're just blown away by it anyway. But so looking at our cross-sectional view, it's pretty good. But when you start getting into the the 0.1 millimeter voxel, the quality is just blown away. We're talking about surface artifacts on the on the surface of the bone, but we just look at the fine detail that we can see with this. Absolutely stunning. And in terms of comparison, again, there's our 0.25 voxel, and you can see the difference in sharpness. There's no software gimmickry being played with these images. It's simply the difference in the in the image quality that we're getting out of the machine. So coming and looking at some specific examples of areas where we might want to use the the HDVI. In root canal treatment, the most important thing you have to do to start off with is actually decide whether or not you want to do it or not. Are we going to extract this tooth, or are we going to do a root canal and endodontic treatment? And with that, it's when the roots are difficult to visualize, and again, classically the 108 and the 208, the upper carnassials, that's where you have the diagnostic challenge. So this was a case that came to me actually in the last few days. I'll see if there's a date on there. But we've got fractured carnassial. This one's fairly easy because it goes up underneath the gum line, so we're not going to be able to salvage that tooth. So we know that's going to be an extraction because we've lost the periodontal bulge. We're never going to get protection for periodontal disease with that tooth, so it's a goner in our hands. However, this one, we've still got periodontal bulge, but it's a long-standing fracture, so are we going to be able to treat it or not? So our standard set of x-rays, we can see some changes around the distal root there, but is it still salvageable? Not sure about the other two roots. So again, we're splitting the roots to try and have a look at them. My clinical impression was this was probably a non-goer, but the client was desperate to have a root canal done on this dog. So we gave her the option, and she went with the cone beam, HDVI, and immediately we can see some changes coming out here with that. But again, increasing the image quality just makes that astounding, the changes that we can see there. And I hope the slides will work okay for this, but working through the sequence, we can see the changes on the roots, and then just going through the next set, even clearer. Whoops, I'll go back, I do apologize. So we can see the changes around the roots there that would mean that any root canal I did was going to leak. We've got a short of doing apicectomies and actually going and doing a retrograde treatment, which again was sort of getting out of budget for this client. This tooth was an extraction case. But again, using the the 3D rendering, just allows us to demonstrate by slicing off some of the tissues, demonstrate nice and clearly to the client the changes we got around those root apices that would have rendered them challenging, shall we say, for a conventional root canal treatment. So, and there are some limitations, and where we're actually looking at a root canal. This is using a combination of materials, so gutter flow and gutter perca. Things don't matter particularly, but that's hence there's a difference in the densities there, whereas we've actually got a nice solid fill, tiny bit of overflow there. But it does make getting the images difficult when we've got such a radiodense material. But again, playing with the 3D, and I know I'm a bit of a numpty because I like the 3Ds as opposed to looking at the slices, but you can see the nice difference between a tooth root abscess there as opposed to a normal apex on the other side. So again, just some fairly random cases for your entertainment. I'm the light relief at the end of a busy day for you now. So dental dysplasia, and this dog was presented with some problems in its teeth, and you can see the abnormal shape of these teeth and obviously problems here. But again, if you look at the shape of the molar here, you can see the changes in the surface. And with this particular tooth, not only we have sort of dysplasia, but also a condition called dens in denti, where the tooth enfolds in on itself and means that the tooth again is not going to be compatible with life as far as that tooth is concerned. But again, you can see obvious abnormalities here as well as the changes on the roots here with that. And what worried me most, and because one of my concerns was a condition called odontoma, was that we had a small radiodense portion here right next to the infraorbital canal. And my question when we sent the samples off to the lab was, do I have to worry about an odontoma, which would mean a second surgery, and dangers of compromising here with this. But fortunately came back simply as a dysplastic lesion. This case is so recent, I haven't got the histology back on it yet. I thought it'd be quite fun to show you though. And here we have a fairly standard looking boxer mouth with bucket loads of proliferative gingival lesions, which I'm sure we're all familiar with. And it's important that we do routinely take x-rays or visualize these patients properly. And we can see a lucency here, which is fairly obvious, and similarly here with this. But I think we'll all agree that that actually makes it pretty obvious what's going on. We have a massive change in this area. Aren't these lovely? These are areas of calcification within the vibrissae. You'll see them fairly commonly, but they're quite pretty to look at. But obviously the main area of problem is here, where we've got massive loss of structure. It does mean that the extraction is going to be easy, but removing the cystic structure was going to be a worry, and with some of the options that we can have for these cystic type lesions, we needed to make sure we had full excision. So we went for a fairly radical approach with this to make sure that we did clear everything out and remove the whole of the cystic structure as well. So there was closure and the post-op CT. Routinely we'll try and do a post-op CT unless we're time pressured, because again it just makes that communication with the clients easier. It doesn't take that long to run off a quick CT afterwards, and it makes the discussion with the client as to what we've done and why we've done it a lot easier to run through. So there's our area of excision extending up into the zygoma there with that. And looking at our slices, we can see the change there. So it's all a nice long time since lunch, so everyone's tummies will have settled. So I can show you these images. This is gross periodontal disease. Hopefully you won't see this too often in your own clinics. And extending down, in a horrific way down on the bottom here. So the X-ray was pretty smart. This sort of area of destruction of bone and reactive changes here around the ventral mandible. But the cone beam CT just really made it absolutely clear what was going on. It really is. It just highlights exactly what's happening with this. So with this case, we went in, again, fairly radical surgery. This dog had been on God knows how many different antibiotics over the years, because you always treat periodontal disease with antibiotics. Anyway, it's a long story. Anyway, we revealed a fairly nasty resistant E. coli, so hopefully this case will be doing okay. There was our post-operative approach. There's still more work that we need to do, but let's sort this thing out first and make sure the dog can survive, and then we'll play the rest of the mouth. So, fractured root tips. Is it all okay? You happy? Okay. So, fractured root tips, quite a common, recognized complication of dental extractions. So again, we get a number of these sent to us where veterinary surgeons have been a little bit hack-handed with their elevators and luxators. So when we're approaching these, cone beam CT is really nice. It lets us know whether we need a lingual approach or a buccal approach to them, and also what sort of structures might be involved in the damage. But this is just a lovely image of that little root tip sat there. So we adopted for a buccal approach with this one, and there's the offending article and taking out. This is another case from a dog this time, and the veterinary surgeon broke the mesial root tip and decided to not to even attempt taking out the distal one and left it for us to play with. So again, we were going in and having a bit of fun with that. But again, these are beautiful images to show your clients. Okay, they're absolutely gorgeous images to show your clients. I know that's not the priority, but it's fun, isn't it? And so, I am a big kid, I know, it's terrible. So, again, using your materials. Am I doing okay for time, or am I? You're okay. So, using your HDVI to think about sort of things that might come up to bite you in the bum during the surgery. And so we have a cat here, obviously with severe stomatitis type problems going on in the back, but we have a fractured canine that's going to need to be extracted as well. So we're anxious just to see exactly what was going on elsewhere. Had there been root tips left in place, because we always need to remove those with chronic gingival stomatitis and so on. So again, cone beam CT was our choice. And just going through the sequence of these, if we look at the canine roots here, you can see the resorptive process going on through that. So we know that extraction is going to be complex. It's not going to be straightforward with that. So say just a number of little clinical cases there for you. But I'm in the privileged position of being old enough and ugly enough not to have had to go through too much research work before getting my diploma. But my residents have to have research projects. And so one of the research projects that we have come up with is the problem of caudal malocclusion that we see commonly in British short hairs and a number of other cats, where we get impact lesions on the gingiva at the level of the lower molars. And the hypothesis is that this is a malocclusive problem related to the upper jaw rather than anything else. And so, again, using the cone beam, we can do these beautiful reconstructions, but also more importantly, using the slices, we can take cephalometric measurements and actually try and give us an idea of what is normal, what is the average, what's the standard deviation across all the cats. Are the cats that have got this malocclusion problem statistical outliers with it? So I'm glad I don't have to do the work. It's down to my residents. It seems to be quite a nice little project for them. But the thought is that it's this inward pointing, this palatal deviation of the caudal mandible, caudal maxillary teeth that is causing the problem. So again, just looking through another. When you're bored, just shout and I'll shut up. That's fine. Presented with this case as a possible tumour and areas of changes, obviously on the gingival aspect of this upper right canine, and also on the mesial aspect there as well. But in fact, it was actually originally seen by my resident, who I was away, not surfing, I was skiing, and when we talked about it, you can see the outward movement of this tooth here, with that. And radiograph was not exactly helpful. Some changes there, but nothing particularly dramatic with it. So went on and did the HDVI, and again we can see the changes here on the bone there, and the obvious deviation outwards. And he wasn't happy enough to go on and do anything else, and I think he took a biopsy tissue of the the soft tissues that came back as inflammatory and reactive. And a few weeks later, actually it was 10 weeks later, the case came in for review with me, and the gingival lesions had healed, and bony structure is actually looking an awful lot nicer. And again, the joys of the HDVI. You just don't get this sort of image with anything else that I've seen. And the structures have healed in here a little bit, and again looking at the 3D. But most importantly, this was the original, the original CT, and you can see the big space here. But at the time I saw it, that's all healed in. Okay, so this was a partial avulsion, and let nature take its course and actually allowed it to get in and heal. Squamous cell carcinomas we're all familiar with, but there's a variant typically in young dogs called papillary squamous cell carcinomas. And as you can see, this is a young dog with mixed dentition. So we've got temporary teeth as well as permanent teeth, and a large aggressive looking lesion here. And it came back as being a papillary squamous cell carcinoma. And so young puppy, only been in the house for a month. Are they going to spend big bucks doing maxillectomies? Decided they'd go for it. So that's great. So off we went. And there was the original and there was my surgical margin, and I thought I'd got everything. I was quite pleased with myself, and surgery, closure, looked nice, settled down. There's the poor little pup afterwards. Bit of facial distortion, but not too bad. Owner's very pleased. The histology report came back with a clear margin around the tumour. Wonderful. However, right at the margin, the distal margin, there was a 0.3 millimetre island of papillary. So, second surgery. Owner's naturally somewhat reluctant, but decided they'd. Oh, have I missed a slide there? Decided they'd go for it. So there was the dog on presentation for the second surgery. Everything healed nicely. Beautiful little dog, lovely. And there was my second surgery, and there was my first surgery, and that's where we got to on the second surgery. And there's the little dog, a bit more distortion this time afterwards. However, this client was in my clinic 2 days ago, came back for a recheck, and there was another client in who was also going to have a maxillectomy on their own dog, and they were very concerned about it. This client persuaded them to have the maxillectomy. So, win-win as far as I was concerned. It was good news. Again, just on the story of papillary squamous cell carcinoma, I think it's a poorly recognised condition, which is why I'm harping on about it a little bit. But you can see the changes here, and the deviation of the upper carnassial and this lesion that's present here. So came back as papillary squamous cell carcinoma. Nasal discharges, please shout when if everyone's deaf. You're happy? Okay, go. Nasal discharges. So not very informative. It's always nice if you get something obvious on the 3D because you can then shut your brain off and go in to do surgery. So going through the sequence, okay, so we're looking at the discharge or the changes here. And I think we'll all agree we've got a lesion there. Even I can see that one. And this came back as a neural sheath tumour. Now, I'd have loved to have had a go with some of these ablation techniques. It would have been really quite fun to have had a try with that. A, I didn't know about them, and B, client had opted for euthanasia at that point with this. So another periodontal disease, just showing you some of the effects that we can see with periodontal disease here. Massive changes to the quality of life of these patients. And by illustrating just how severe the changes are, it does actually help encourage those owners to get the toothbrush out and to use the toothbrush, and probably more importantly to tell their friends about it as well, so that hopefully we're avoiding some of the the distressing problems that we see as a nature of the systemic spread of the infection from these periodontal diseases. So we always think of oronasal fistulation as being one of the consequences of prolonged periodontal disease in the canine teeth, but not always the case. So, cone beam CT, do we need to? We know what's going on here. No, we don't. This was squamous cell carcinoma. And I don't think I've ever seen anything quite as severe as this. Absolutely horrendous. So there was no way that was going anywhere apart from the big bag, I'm afraid. Okay. So again, more common sort of oronasal fistulation is down to the presence of periodontal disease and loss of the alveolar bone support, but you'll also get it elsewhere as well. So don't just think about the the obvious lesions that we can see with these here. So not all oronasal fistulas are the canine teeth. We do need to think about the back of the mouth as well. And here we can see the destructive changes with that. And here you can see the areas of destruction going through, and the changes within the nasal. That was nice, being able to pick up the the pure communication there with that. So this debrided the area, cleaned it up, and then using a bone graft sheet, and then closing the tissues over with a releasing incision, and it's done very, very well indeed. TMJ imaging. When I did my exam, you had to take radiographs of the TMJ. That was fun. The AVDC, the American College, have actually now removed radiographic imaging of the TMJ from their requirements, quite rightly, because you can't see the ruddy thing on the vast majority of radiographs. But even with cone beam, it can be easy to miss things. So you do need to look. So a nice TMJ, nice looking TMJ, looking inside the mouth, not so nice looking. So making sure you're not just simply skipping over things obviously is important. And when you come to looking at the obligatory slices, we can see a large number of changes there. So again, just being aware of that. I mentioned odontomas. So this is a complex odontoma, and basically the body has decided to create new teeth and has got a little bit disturbed and is just ending up producing these random little denticles, as they're called, these tiny little blobs of tooth material here with that. So dentistry is fun. There's lots of exciting things in dentistry. The other variation of an odontoma is a compound odontoma, and this is where the dog is trying to produce a proper tooth in this area. So you can see much more of an attempt to try and produce a tooth there, rather than sort of random denticles that are being produced beforehand. I'm getting towards the end of the time, or are you happy we carry on? Please vote with your feet. Carry on, yes? Carry on. Sure? Okay. Yeah. There's a few hard nuts here that want to carry on. So retained temporary teeth. Why are you doing a CT for retained temporary teeth? Well, easy, but there's our upper retained premolar, and on the bottom jaw, again, retained premolars. But the effect of that retention, or the lack of eruption of the permanent tooth, has allowed that temporary tooth to stay in place. And the lack of eruption of that permanent tooth then leads to the formation of a dentigerous cyst. And that's where we can get problems. So don't ignore retained temporary teeth. So embedded teeth can be a little bit more dramatic. So this is an embedded upper right canine, riding all the way back into the nasal chamber. No history of trauma with this. Appears to be developmental as opposed to anything else, which is rather bizarre, but can't find any explanation for it otherwise. Trauma cases do form a significant part of our workload, I guess. And casually, veterinary dentists say the worst thing you can do with a trauma case or a fracture in the face is to allow an orthopod anywhere near it. Because screws and plates don't mix very well with the majority of our facial fractures. So often a simplistic approach, especially in a young animal where we've got all the developing teeth on the inside of the jaw, is to adopt a very conservative approach, simply using acrylic sprinting. And there's all of our developing teeth, but we're trying to avoid damage with those. And the HDVI afterwards showed beautiful healing of that, and went on to do really well. And amazingly, no damage to the developing permanent buds, which was fantastic. Symphyseal separations, we see these a lot in cats, obviously, but when we're thinking about the skull, we have to remember it's a box. And if you knacker one side of a box, you're going to damage one of the other sides as well. So there's always going to be other damage. So whenever you get a symphyseal separation, always have a look around the rest of the mouth as well. And you'll frequently find a number of other changes there with that. And something that would have missed completely without doing good quality imaging. And so stabilized maxilla and the mandible. And again, taking a fairly simplistic approach, that's all we did. We didn't dive in and try and fix any of this. but nature knows better than many of us. And so allowing nature to take its part and to allow healing, providing you haven't got problems with it, can often be the simplistic approach. So it did really nicely. Green stick fractures, again, young growing animals. I call them green stick. It's not a proper term really, I guess, for them. But fractures, but then multiple separations, here with that. And again, they can be worrying, but will often sort themselves out. But do look for the other areas of damage that we're going to see, with that. You can see the changes in the nasal bones here and the facial bones. We do see occasional exotics. Anyone want to guess what this is?
Monkey.
Perfect. Okay. So yeah, little monkey. Tiny, absolutely tiny. It's a handful. That's all. So yeah, a little bit of a challenge under anaesthesia. A rather poor image of a chinchilla. It's one of my disappointments is that a colleague with the exotics wasn't here today. I was going to badger him about getting settings and things for that. So that's something I'll need to badge you guys on for later on. So, any questions, any thoughts? And apologies for overrunning.
Hey, Bob, excellent presentation. Quick question for you. If you were to guesstimate how many findings you see from your dentals in the nasal bulla and TMJ, what would you estimate that to be?
I think following trauma, there's actually been a paper published in the Journal of Veterinary Dentistry within the last year that showed something like 30 to 40% of facial traumas actually have some damage to the TMJ. It was a very high percentage. I could be misquoting. It's from the team at Eastcote Vets in the UK. It's a nice paper, but it's very, very common, frighteningly common. Most of them will go undiagnosed. And we used to worry a lot about getting TMJ ankylosis after trauma, but when you start looking at the total number of diagnoses, there's actually very, very few that ankylose. So I think it's a worry that we've had unnecessarily.
How about the nasal and the bulla?
I don't think there's any stats on that. I don't think there's any.
I mean, your practice, what you see. I've heard from in the States 10 to 15%.
Yeah, that would be my sort of reckoning, but I've not thought about it, so that'd be my guess.
Thank you for the excellent presentation and the beautiful images. What I would like to ask, I have a friend, a colleague that loves dentistry in Greece, and he brought a CPCT, and I told him, why not a Vimago? And he said, I need only the scalp. In how many cases do you evaluate the lymph nodes or the thorax?
Not enough, I think is the honest answer. A lot of our facial tumors are locally aggressive as opposed to widespread. So we have a sort of a margin to get away without that. But again, one of the reasons why I wanted to come was to get some better advice about using contrast medium and running it through and evaluating the chest. And the joy of the Vimago and the reason I bought it was you have that ability to get the whole chest scan. And there was a mention about a 40 kilo suggested sort of limit. No, we've had 60 kilo Great Danes going through the Vimago. The biggest problem is lifting the ruddy things into the room. That's the biggest problem. Once they're there, fine, you can run it. There's plenty of space within the donut to run through really big dogs.
Thank you. Because I had the same impression. The great advantage is that if you want, you can see the lymph nodes, you can take samples, and you can see, just with the same machine within the same catch.
Yep.
It was very impressive. Thank you. So we're done. Do you have any other questions? No, I have one question. So Vimago is a CBCT or HDVI. That's the goal, remember.
Different.
Thank you.
It's way different.
Thank you. It's
You
different.
have to remember that. Me? I learned it today. That's an HDVI because we have a lot of differences. So we cannot compare to other CBCT because it's a very different technology. Similar but different. Thank you.